Welcome everybody who's showing up, and we are glad to have you aboard. I want to begin before I actually introduce our speaker today. I want to uh, do a couple of things, announcements. One for clarification. Some of you may have signed up for the pre-conference workshop of the AAPC conference in Berkeley. This is a one-day adaptation of the Sex Attitude Reassessment Workshop required for certification by ASEC and other sexology organizations. It's designed to assist helping professionals, and not just chaplains or counselors, but lawyers and others, doctors, uh, work with sex issues with a wide variety of clients and patients. SARS sufficient for certification are generally 4 to 6 day programs. So this one, while it will be valuable, especially for those who are working with returning veterans, will not suffice for certification. End of clarification. Um, Second piece is technical. During this presentation, you may ask questions by entering things in the chat box, entering your question in the chat box at the lower left of your screen. That will send it out to everybody, and our presenter can read it, and then she can respond to it as it's appropriate within her presentation. So much for technical and clarifications. Now for our presentation for today. The webinar is the second offered by the Veterans Affairs Chaplaincy Service and the American Association of Pastoral Counselors in collaboration. Our presenter for this program is the Reverend Penny Phillips, a chaplain at the Palo Alto VA facility. Penny Phillips has been at the Palo Alto chaplaincy for more than 16 years, has wide experience with various facets of chaplaincy. She provides spiritual care, pastoral support, and bereavement counseling, among other things. Probably a lot of hand-holding as well. In addition, Penny is board certified in the in the Association of Professional Chaplains, as well as the National Association of VA Chaplains in Palliative and Hospice Care. She's on the faculty of the Palliative Care Fellowship Program and has presented several times both at APC and at the California Hospice Foundation. Penny is ordained in the United Church of Christ. One fact, though, that sets Penny apart is that she's the only presenter we've had who speaks Mandarin Chinese, but she's promised to speak only English today. Your turn, Penny. Over to you.
Thank you very, very much, David. Thank you. I'm very happy and honored to be part of the pre-AAPC events, conference events, AAPC Pacific Region. And I'm very grateful that the topic this year is responding to the diverse needs of our veterans and community through psychosocial and spiritual models of care. I'm very devoted to veterans, and so I really appreciate that you all have chosen this as a topic and a focus. And today, I especially want to thank David Tittle for all of his support and encouragement, and my colleague, Chaplain Charles Wilson, who has been essential to getting this off the ground and getting all of the technicalities smoothed out. So I'm very, very happy to be part of this today. I am going to really focus on veterans, give you a little background on some veteran cultures, because I think that's essential to helping us really understand all of the different facets of serving veterans. And then we'll also do something about spiritual issues and some interventions that I think we can all be aware of and participate in. In the very beginning, we'll talk a little bit about actually palliative care and hospice, how they are related and how they are not related. So we're going to cover a lot in the next hour and plus minutes. And please feel free to send a message in the chat box, and I will try to respond to it at the appropriate time and with the appropriate topic. So the first thing is, I'm going to ask a little survey, as I usually do when I'm presenting to different groups in the community and even within the VA. How many of you today are veterans or know a veteran? And it's just a yes/no response, and you'll be able to start the voting right now. On your screen there'll be a yes or a no, and so you're able to respond to that, and I'll just wait a couple of minutes here. Just a simple yes or no. Are you a veteran, or do you know a veteran? And that will give us just a little bit more information about our participants today. And we'll wait another half a minute here. As I said, I often ask this in groups that I present to, and invariably there are many veterans in the group, or almost everybody's hand goes up because they know a veteran in their work setting or certainly in their family. So I'm going to stop the voting, and it is about 83% today of you are veterans or you know a veteran. And I think this is indicative of the general communities that we're a part of. Veterans are everywhere, and they may not always identify themselves, and it's up to us to perhaps encourage them to be identified so that we can really get to know them and provide the best spiritual care, the best kind of care. Today I'm wanting to show you the learning objective, identify 3 U.S. military veteran cultures. We're going to clarify the role of hospice in palliative care, and then we'll also be talking about spiritual care issues for vets at the end of life. There's many of them, but I hope you'll be able to name 2 at the end of this presentation. And I just, by way of introduction, want to talk about culture. Military service is an acquired cultural experience that continues long after discharge. The cultural context of veterans can have positive and negative influences on their health care. It can impact their choices. It can impact their end-of-life care. It can be, their military experience can be a source of strength and a source of conflict. And by culture, I mean all of the integrated patterns of human behavior. It includes language, thoughts, communication, actions, values, beliefs, institutions of racial, ethnic, religious, or social groups. So culture is a very inclusive word for me, and the military service is its own cultural experience. And then just to back up a little bit, to introduce palliative care and how it relates to hospice. One way to describe it is palliative care is the large umbrella, the large discipline, of which hospice is one section. Palliative care is now a recognized specialty. I'm sure everybody knows that in the medical field, and one can be certified and licensed and registered in palliative care specialty. So palliative care is here for whatever the prognosis and whatever the illness. It's about managing symptoms, managing pain, nausea, other distressing symptoms. It affirms life, and it regards dying as a normal process. Palliative care does not hasten, nor does it postpone death. Palliative care is often presented from a team approach. So psychologists and chaplains, spiritual caregivers are part of the palliative care team. We offer a support system so patients can live as actively as possible. It's really about living, preventing suffering, dealing with the symptoms, and being very proactive. And we offer a system for the family and the caregivers to cope. It is a group approach, if I can say it that way. And as I said, a team approach to address the needs of patients and families. So the team might be, pharmacists, volunteers, spiritual caregivers, massage therapists, all kinds of disciplines. Music therapy is on our team here at the Palo Alto VA, and of course, medicine and nursing, of course. But it is a team approach in the palliative care program. And we are about enhancing the quality of life. We also have an occupational therapist on our team who will assess for mobility to expand the person's quality of life in terms of, is a motorized wheelchair appropriate, or some kind of a walker or whatever. So occupational therapy does mobility assessments and evaluations. And palliative care can start very early in the course of the illness. We've had people in our palliative care clinic for years because of different needs, different kinds of symptoms that they're dealing with. Some choose to be in hospice at the end of life. So I've said on this page here, hospice is palliative care at the end of life. And generally, hospice care in this country is mostly provided in the patient's home. That's where it has started. But now we see more and more respite facilities, inpatient hospice units, as ours is here at the Palo Alto VA, and many nursing homes now and assisted living facilities will have avenues of hospice provided, being able to be provided to their residents. So the hospice care can be, now is provided in a variety of settings. And I wanted to point out on this slide too that therapies such as chemotherapy or radiation treatment can be part of palliative care. I just want to lift that up because I think some people think you're in palliative care or in hospice, you are not allowed to have any more chemo or radiation, and that is not true. Now, the chemotherapy or radiation is geared for palliation rather than cure. But we certainly have had hospice patients who receive radiation for palliation of their symptoms. So it's a fine line, but there is a difference there, palliative care and hospice. So I want to say that all VA hospitals now, all veterans hospitals, have a palliative care consult team with varying members on it, varying disciplines, depending on the setting and depending on the veterans hospital. But all VA hospitals have a palliative care consult team. And many, many hospitals now in the community have palliative care physicians, palliative care consult teams. So I hope wherever you are that you're familiar with the palliative care programs in your community because it's a very growing, important choice that people have in medical care. I wanted to back up just a minute to say that one thing I'm not talking about today, but I think is very important, is, and people usually end up asking me about it in one way or another, is about veterans' suicide rate. And I'm not dealing with that, although I think that deserves its own webinar. But talking about suicide in the veteran population is very is very challenging, and it's very, very important. The VA takes this very seriously and has spent a lot of time and money and effort on dealing with suicide rate and how we can reduce it, how we can take care of the suicides rate for veterans. For every soldier killed in war this year, about 25 veterans take their own life. This, of course, is unacceptable. It's an outrage. 100 Americans take their life every day in this country. This also is an outrage. So I'm lifting this up because I don't want to gloss over it, and yet I'm sure some of this is going to bring up concerns about the suicide rate for veterans. And let me just say, I think that deserves its own time and energy. We are taking it very seriously in the VA, and there's all kinds of programs and emphasis and serious consideration about how we can reduce the suicide rate for veterans. So we are now going to go into a little bit more of the veterans' demographics and cultures. We have more than 23 million living veterans now in the United States. And actually, this says 3,000 Pearl Harbor. It's now about 2,800, actually. And active duty deployed U.S. forces now women are about 15%. And in World War II, by comparison, it was 2%. So that number will continue to grow. The largest group of veterans, as you may imagine, is from Vietnam, almost 8 million. 60% of veterans live in urban areas. We have 2 million veterans from Iraq and Afghanistan global war on terror, and obviously that is not yet completed, those numbers. And we have had all volunteer forces for more than 35 years. New recruits are young, often fresh out of high school. Some search for adventure, better economic circumstances. They search for community. Some want to escape difficult circumstances, and some, all of the above, in the new recruits joining the military today. Their basic training, actually, the purpose is to turn them into squads of fighting men and women. They are built on discipline, privilege, duty, connectedness. And by privilege, I mean everything that they do can move them up in the status. There's a very defined system about how one moves up in the military, up and into higher positions, based on a very defined system. They are initiated actually into a warrior class. There is unique language, there's military jargon. They learn to dehumanize the enemy, and slang is often substituted for the actual word killing. So they use terms like, he was zapped, I took him out, he was greased. I think as a way of distancing themselves from this is actually a human being. They're trained to dehumanize the enemy. There is battle mind training, one for all for one. The buddies, their squad really becomes their family, becomes their community. Very, very tight, very, very committed to each other. They have each other's backs, and it's very essential that they become that close. We've had young veterans here on our campus in the polytrauma unit, 19 and 20, who have multiple issues, multiple trauma, and they feel guilty about being here because their buddies are still in combat. and they feel very guilty that they're not there with their buddies, with their family on the combat line when they've been so injured that they're not able to be there, and yet their overwhelming sense is, I don't want to be here. I've got to get back to my buddies. Stoicism is promoted, no pain, no gain, and admitting fear or pain is often seen as a sign of weakness. And I just want to reiterate, this is men and women in their basic training. This is what they are taught in their preparation to be soldiers. In World War II, which was the early 40s, almost all World War II vets now are over 80, and some are in their early 90s. The last World War I veteran, by the way, died in 2011. The World War II veterans, many died or were wounded on the field in battle, and there was a distinct front line. You knew where the front line was, and behind it and in front of it, it was very clearly delineated. There was pride in the American victory over fascism. There was no TV coverage then, so we didn't see a lot of brutality, the war brutality. Entire countries supported the war. They came home as heroes. There was a definite end to the war. There was, however, segregation in World War II. Actually, one of the finest, most decorated units in World War II was the Asian American unit in the South Pacific, and yet they were clearly segregated, but they went on to become the most decorated World War II squad. Many World War II veterans today have injuries from combat or environmental exposure, radiation, mustard gas. A lot are living with those kinds of injuries today. The Cold War was generally the early 50s. It sort of spread out through the 50s, the arms race. Veterans had a lot of radiation exposure to above-ground nuclear testing. A lot of anger started, mistrust of the government, including VA services. Every VA now has a registry physician for treatment and benefits of Agent Orange, Gulf War syndrome, ionizing radiation. And I lift this up because for many veterans at the end of life, it's very important for them to settle their claim, their medical claim, in terms of financial support for their survivors. So this can be a very important thing that they would love to have resolved before they die. So every VA hospital has a registered physician for these kinds of claims, for these kinds of benefits as a result of military service. So you may want to keep that in mind and if you are dealing with a lot of veterans in your community, be aware that the VA hospital has a physician that should be connected with the veteran if there's concern about their medical status, their claims from service. The Korean conflict, early 50s, unfamiliar to most Americans. It was never declared a war, no clear victory. Environmental exposure, there were extreme heat and cold, and even today Korean vets deal with cold sensitivity and very temperature-oriented concerns, health issues. And they may actually minimize their experience because nobody really paid attention to it, or we didn't really know that it was even going on. That's how Korean vets sometimes look back and see their experience. Vietnam War started in the 60s and went into the early 70s, source of much angst for the United States. The television coverage was actually in our living rooms. We saw the war over dinner. We were exposed to it on a daily basis, and it was very up close. The draft forced many into the war at that time, the war that they opposed. At that time, soldiers required only 1-year tours. Not to say some didn't volunteer to go back, but the minimum was a 1-year tour in Vietnam. It was very controversial. Distrust of political leadership. It was the first guerrilla war, which meant that the enemy was everywhere. You couldn't trust the people around you. It was hard to know the combatants and the civilians, and soldiers could never let their guard down. There was no front line. It was everywhere. That's guerrilla war. It was hard to have a sense of completion or a sense of accomplishment. Great emotional, existential trauma, great physical trauma, and the severely wounded in Vietnam were more likely to survive due to amazing medical care on the field, in the medical tents. We know that reintegration for those veterans has often been difficult, even today, 35, 40 years later. A lot of alcohol and substance abuse, many mental health issues for our Vietnam veterans. PTSD, which I'll talk about in a little bit, many of them suffer from PTSD. Agent Orange was used there. Hepatitis C is a medical issue for our Vietnam vets. And TBI, traumatic brain injury and polytrauma injuries. As I said, a lot of them survived incredible injuries on the battlefield due to improved medical care. And now they're living with traumatic brain injury and different results from the polytrauma injuries. The Gulf War, early 90s, and many were exposed to environmental toxins, burning oil fields, depleted uranium, multiple vaccinations because we didn't know what toxins they were being exposed to. There were many unknowns in the Gulf War in terms of what was being used in combat on the battlefield. Gulf War syndrome has been definitively diagnosed, memory loss, fibromyalgia symptoms, so many of our vets are dealing with that. Desert Shield, Desert Storm, that was the term, the name for this particular conflict. Two conditions correlate with that service, ALS and respiratory problems. A lot of asthma in our veterans due to the high levels of smoke as a result of the burning oil fields in the Gulf War. Now, the young age of those vets, or these veterans today, mean probably few need palliative care now, but this is going to be a big consideration in the future, and it will change as the population and the veterans get older. 8,000 people are turning 65 every day in this country. 8,000 people are turning 65 every day. And so these younger veterans are going to be coming of age, so to speak, in the future, and that we just need to be, I think, aware of that and anticipate that some of these Gulf War veterans will be in our palliative care clinics. The global war on terror started in the early 2000s. OEF, OIF, OND, OEF, Operation Enduring Freedom, Operation Iraqi Freedom, Operation New Dawn, OND, was a term that came out in late 2009 or early 2010, and it was a term from the White House to describe the winding down of the military presence in Iraq, but some of their veterans were definitely a part of OND. So these veterans, early evidence suggests there's a great psychological toll, and it will probably be worse than a physical toll. Prolonged exposure to combat stress over multiple rotations. And the Department of Defense now is trying to establish a baseline mental health assessment prior to combat for all of our soldiers. So there will be a baseline to have so that when the soldier returns and starts exhibiting symptoms or feels that there's been some trauma as a result of his service, there'll be a baseline to compare to and to make it a little bit more fair in their evaluation or assessment. So the Department of Defense has done that, I think, for a couple of years now to establish a mental health baseline prior to combat. Several groups, veterans groups, are already reviewing care of the veterans from the global war on terror. There's an increasing incidence of suicide and suicidal attempts for this group of veterans, high numbers of depression, PTSD, and moral injury, which I'll talk about in a little bit, and also traumatic brain injury from the types of weapons that are being used in Iraq and Afghanistan. And I just wanted to include the culture of for our homeless veterans. 23% of homeless are veterans. That's a national figure. And I believe homelessness is a culture in itself. So on top of being a veteran, on top of the culture of your particular conflict where you serve, then there's also the culture of being homeless. And many veterans are unaware of their VA benefits. They are mistaken often that they only served a year, so they don't have any benefits, or they never were in combat, so they don't have any benefits. So there's been a big push to educate veterans about who is eligible and to get them enrolled. Of homeless veterans, almost half served in Vietnam. Almost 90% had an honorable discharge, and that's a key requirement for getting into the veterans' health care system, having an honorable discharge. Really doesn't matter how long you served or where you served, but that is a key point of access to the VA healthcare system. Many are mentally ill, many have substance abuse problems, and to get them tied into some of the VA clinics and outpatient programs can just be a real benefit to the community and certainly to the veteran, but to everybody, to let them know that there are some benefits that are available to them. Veterans' unique characteristics, combat or non-combat experience. Nowadays, veterans say there's no non-combat experience. Everybody's in combat. Up recently when women soldiers are trying to get recognized as being in combat, even though it's the old definition and it limits them in their progress in the military. And so they are bringing to our attention that in Afghanistan and Iraq, everyone is in combat today. Several conflicts ago, there was a distinct combat or non-combat kind of experience. Another unique characteristic is the war or the era they served, the cultures, which is what I'm talking about today, whether they were prisoner of war in whatever conflict they were in. And by the way, prisoners of war get medical care and dental care provided for life from the VA healthcare system, which is as it should be, but I just want to bring that to your attention. All POWs get medical and dental care from the VA healthcare system. PTSD is a serious medical situation here. It is not unique to veterans. And I always want to note, most soldiers are able to integrate the experience into their lives as naturally resilient people. The VA is studying this group of veterans. If they're in the same squad and some come back with distinct PTSD trauma struggles and some do not, they're trying to study the ones who do not display PTSD to learn from them about what makes them resilient and how can we nurture that and support that in other soldiers. Branch of service and their rank can be a defining characteristic for them. Whether they were special forces, in intelligence. Even today, there are World War II veterans whose work in intelligence they cannot talk about. They had such kind of intelligence work in their service that they have never been allowed to talk about it. That certainly is a unique characteristic for some of our veterans, whether they were enlisted or drafted. And then another consideration is family history of serving in the military. Current geographical areas, some are very, very prone to having more military soldiers in their area. In some families, it's a tradition. Great-grandfather, grandfather, all the way down to the great-grandson has always served in the military. And it is part of their culture. And I want to remind us that there's a lot of sources of severe stress in a war zone other than the direct combat exposure. There's the extreme physical demands, tedium, boredom, very long hours serving in the combat zone. There may not be a real sense of accomplishment. Every day is like starting over again. Same boring routine. Inability to fix things, lots of worry about family back home. What can I do this far away and in this setting? Poor and crowded living conditions in the combat zone, dangerous working conditions, many not just on the combat fighting area, but there's injury and death in your community, in your buddies. And this all adds to more stress, more and more stress for our veterans today. And I bring this up because it is something to keep in mind as we serve our veterans, as we provide spiritual care, as we deal with them at the end of life, and as they move through palliative care and perhaps end up in hospice. All of these things can be part of our plan of care considerations. And I have another question poll I would like to share. And this is about how many of our returning veterans in the last 10 years have received a diagnosis of PTSD. How many of our returning veterans in the last 10 years have received a diagnosis of PTSD? 1 in 4, 3 in 5, or 5 in 10? And I'll just let you think about that. What is your sense? In the last 10 years, have we a diagnosis of PTSD? Okay, just another half a minute here. Okay. We had a third say 3 and 5. Oh, it's all about a third. 1 and 4, 3 and 5, or 5 and 10. It was all about a third. It's actually 1 in 4. 1 in 4 come back or in the last 10 years have received a diagnosis of PTSD. That's about 25%. And I think it's significant. Now that still means three come back and are resilient, and they come back into their work setting or into their family life, and they are integrated back into the society. But that one person really needs a lot of our attention. And I'm going to talk a little bit more about PTSD, but I also wanted to put this in as a little invitation to do our own self-assessment about how our own values and beliefs influence our attitudes about veterans, World War II veterans, Iraq, Afghani vets. What do our own values and beliefs say? How do I feel about a World War II veteran versus an Iraqi veteran? What is in my background or my bias that might get in the way of my being really present with an Iraqi veteran versus a World War II veteran? Just an invitation for a little thought on our own way we deal with this. We have to become aware of our own cultural beliefs and attitudes in order to be really competent, culturally competent for our veterans. And we really are trying to understand our veterans and never assume. You know, it's very interesting, but I need to bring up that not all veterans get along with each other. Just because they're veterans, even from the same conflict, doesn't mean they're going to get along and support each other. I think we might make an assumption that because they're all the same age or they're all from the same conflict, that we might have a little support group going on here, and it just doesn't always work that way because they've had such an individual experience, or their families might be so different. So we just can't assume. You know, I like to say when you've met one veteran, you've met one veteran, and have to see that veteran onto him or herself. So, another polling question. This is the last of 3. And what is the number one question from veterans at the end of life? Is it when will I die? How will I die? Will my family be okay? Where is God at this time in my life? And this is based on my own, this is not a scientific survey at all. This is based on my own experience, 16 years here at the VA. What is the number one question from veterans at the end of life? Okay, another half a minute here. Another half a minute. I just want to make sure I'm reading any messages that come in. Have there been any? Or? Oh, okay. I want to remind you to any comments or messages in the lower left-hand screen. You can write that, and then I will be reading those. So here we are. I'm going to stop the voting here. And what did we do? How did we do? What is the number one question from veterans at the end of life? Most said, will my family be okay? And then 75% and 25% said, where is God at this time in my life? Based on my experience here at the Palo Alto VA, the number one question that I hear at the end of life is, how will I die? Am I going to bleed out? Am I going to die because I can't breathe? You know, I'm going to be struggling for air. Is it going to be like drowning? How will I die? Once they get that information, once we can tell them, in our experience, this is what it's going to look like, and we're on top of it, and we're going to keep on top of it, they can really relax, if I can use that word. They relax into the process. And then, okay, is my family going to be okay? Is my family taken care of? I know I'm going to be with God. I know I'm going to see the other family members that have gone before me. Then they can deal with that. But it's often they just need the knowledge of how is this going to look in the coming days and weeks. And are you taking care of me? I mean, is it all going to be taken care of when in the dying process? So again, based on my experience here, how will I die? And once we can tell them that and assure them that we've got it covered, then they can really move into other areas. And I put this up here just for a little more thought too, self-assessments, things to think about. What do you think might be spiritual issues that a veteran deals with at the end of life? Just in your practice, in your ministry, in your work setting, what do you think might be spiritual issues that a veteran deals with? And are they different than non-vets? I throw that out there for us to think about. And we've already dealt with the number one question from vets at the end of life. What do you think, and there's been a couple responses, which is great, what do I think might be spiritual issues that a veteran deals with at the end of life? Guilt and forgiveness. I would think, in my experience, that's pretty significant. Almost 100%, I would say, for veterans at the end of life. Is that different from non-veterans? Non-veterans certainly have guilt and forgiveness issues. I think it can be a little more intense for veterans if they've been involved with killing and they're, having to deal with that. So I think what might be spiritual issues a veteran deals with at the end of life, are they different? I'm not sure it's different, but that might be more intense and a little bit more, sensitive, if I can use that word as difference. And yes, another person commented, they're asking, what was my life about? I think veterans deal with that as well as non-veterans, though. I'm not sure that's only a veteran issue. What was my life about? Did my life have meaning? Definitely veterans deal with that at the end of life, as do non-veterans. This is a little small printing, but these are categories for spiritual distress. And they overlap. There's a lot of gray areas. But I put this up here because I think it helps people be a little more concrete about spiritual distress, if I can say it that way. So not that these are all inclusive, it's just a way of trying to help diagnose, identify, and be a little bit more specific about the person's distress. Now, in the middle of the page there, spiritual guilt, moral injury, and it says, I've killed human beings and that is wrong. generally moral injury, and that term has come out of the PTSD mental health communities. Moral injury has to do with, I'm going to read this because I think it said it very, very well. The lasting psychological, biological, spiritual, behavioral, and social impact of perpetrating, failing to prevent, or bearing witness to acts that transgress deeply held moral beliefs. It has to do with individual guilt and shame. PTSD, one of the single most influential risk factors for PTSD is having killed a person. Moral injury is the deep, deep struggle of one's own moral values that have been changed or proven to be wrong or proven to be quite a struggle for the individual. For example, the obvious one is you grow up in church and you learn killing is bad. If you kill somebody, you're bad. Period. Well, the soldier comes back into his church having killed in his military duty and now finds that he's bad in church. And this is a very, very deep pain. It's a deep moral injury for the soldier to have to struggle with. I always think of Ira Byock's comment that the individual gets a diagnosis, but the family gets the illness. And I think the family of the veteran, of the returning soldier, it's a family affair. We can't just look at the veteran by him or herself anymore. And so when a lot of churches now coming back, veterans coming back, they're trying to make it a family support system and not just focus on the veteran, him or herself. But to get back to moral injury, I think what we have to do is allow the telling of the story over and over and over again. There's actually a therapeutic process that in our PTSD program in Menlo Park, the Menlo Park, it's a nationally recognized PTSD program, where the intention is to the veteran tells his story over and over and over again, so that it becomes less powerful. Now, this might take weeks and months, but the theory is to get the story out so it gets less and less powerful for the veteran. I think moral injury is like that as well. We have to provide a safe environment, a non-judgmental environment for the veteran to tell his or her story. And the veterans that are dealing with moral injury, they struggle with forgiveness. I've had veterans say, I know God forgives me. I can't forgive myself. And for us as spiritual caregivers and to be chaplains with these people, we have got to accept this person and say, I'm here with you, and I want to hear your story. I want you to express this pain and have it be accepted. You know how a wound, you open it up to the air and it helps healing? I think that's a good analogy for moral injury. We're trying to get it out and exposed to the air so that it can heal. So forgiveness, very, very powerful part of the care that we need to remember for the veterans. And I think the bottom one here is spiritual despair, hopelessness. I hope that whatever we're doing throughout our ministry, whatever setting we're in, that we're hopeful people. I mean, in hospice, they say, it used to be, oh, there's nothing else we can do. We're giving up. There's no more hope, so he's going to hospice. Well, hopefully, nobody is saying that anymore, because, of course, even in hospice, there's still hope. It's wonderful, wonderful, hopeful place. Hope changes. Hope is dynamic. Hope is, we need to wrestle with it and let it change it as we change. Hope is not a heavy burden box that we put on the shelf and then, oh yeah, I've got hope, and that's it. Hope is something that we have to keep with us and encourage and nourish and nurture. And even in hospice, we have a lot of hopeful people. Hope changes. And I think we have to be instruments of hope in our daily settings. I'm just wanted to see if there was anything else I wanted to pick up. If anybody has a little something to add or another category, please let me know about that. This is just one attempt at trying to organize categories of spiritual distress. Special challenges dealing with the veterans, those that have PTSD, traumatic brain injury, polytrauma injuries. It takes a team. It takes a team to really provide the best intervention, the best plan of care for these veterans. Military sexual trauma needs its own specialists. Chaplains need to be part of that team, but there needs to be special professional therapists and medical people working with the veterans who suffer from MST. Agent Orange, still after all these years, many veterans making claims, dealing with what happened to them 40, 45 years ago. And I want to bring up the special challenge of grief at all levels and all stages for our veterans. Sometimes I think we forget that veterans are, they come across as pretty tough and very capable people, and yet there's a lot of grieving going on in our veterans that we may miss or label it as something else. I think there's grief for themselves, for their own military service perhaps, but also all of the deaths that they may have had, the losses, what they've been asked to do. It's not just grief for death, of course that's part of it, but it's grief at all these different levels for all of the things that they might have been involved in, the grief that they've missed so much at home while they were serving. I'll just leave it at that. Grief at all levels and stages, I think, is very in the veteran profile. Guilt, moral injury, forgiveness, we talked a little bit about that. And distance from church, spiritually, after serving. I touched on that, but my point is what we've learned in church as a young person, as a teenager, and we go back to that church as a veteran, it may not jive anymore. And the veteran may need to find a different church, a different worshiping community. One of my resources, which I'll point out at the end, is an amazing book, I think, about Welcome Them Home, Help Them Heal. Pastoral care and ministry with service members returning from war. The VA chaplain's office is making a big push about educating local faith communities about how to welcome back veterans into their faith communities. And so we're taking that very seriously and developing some education programs and have great programs that are available for local faith groups to encourage them and to support them as they welcome back veterans into their faith communities. So that's what I mean by distance from church spiritually after serving. Financial distress, family dynamics, always a consideration for veterans, loneliness and isolation. Final hours, let me back up, loneliness and isolation. And, you know, a veteran can be in a large group of people and still feel isolated. And to help identify that and to talk about that, I think can be very healing. And in the final hour, seeing people who have died, this is at the end of life. Many people at the end of life will see people who have died and will talk to people who have died. They see them in the room. And for families, this can be upsetting. And they can say, they'll say, oh, now, Dad, remember, you know, she died many years ago, and so she died, and you're here, and so you don't need to think about her. And we tend to say, well, I think let's go where he is. Let's talk about who he's seen and what are they wearing and who else is there, and to normalize this experience, because they may actually be seeing those people and to talking with them. Now, if it's upsetting, and you can tell that just by watching the person and see if they're struggling or they become quite agitated. What has happened for us as the hospice care team is to say to the person in their struggle, you are in charge. If you do not want to see these people, you stop it. You can stop this. And invariably that will change the person's reaction to what he or she might be seeing or hearing, to make sure that the person dying is in control, that they can say, stop, I don't want you to be visiting me. I mean, not in words, but you know, they'll have that strength in them to be able to stop that. But we do, when it seems to be comforting, then we will try to model for the family how they might learn more about what their loved one is seeing. And this sometimes happens days before a person dies, maybe just hours. And it's not for everybody, but it does happen. Interventions to the veterans. Just wanted to put up a few ideas here. Normal interventions are appropriate, and for non-veterans and veterans, you know, life review, a ministry of presence, active listening, exploring beliefs, values, their spiritual journey. You know, what are your own interventions that you use in your ministry, in your work, in your pastoral care? What are the things you're already using? Because that's probably going to fit for veterans. I think it's key to create safety, to build rapport, to build trust, for all of our people that we interact with, provide a non-judgmental setting so that we can really get to know these people and that we can really hear their story. And that takes time. That doesn't always happen in the first contact, but I think that's a goal that we have to aim for, creating safety to build rapport and a relationship. Thanking the veteran for his or her service. This may invite dialogue or not. Some veterans are quite shy about it. Others will stand up taller and prouder. I usually lean on the side of offering, you know, to say thank you and having no response. I'd rather have that than not offering my thank you, because my experience says that it does open up a little avenue of connection. I still have Vietnam veterans today, when we say thank you for your service, they will still often say that's the first time anybody said that. Remember that stoicism might interfere with acknowledging emotional or spiritual or physical pain. They've been trained. They've been trained to be tough. And many of our veterans have a varied drug use history. And that needs to be part of the assessment and part of their history. We need to be very aware of that. I think going slowly is key, and listen for what is not said. There's a lot of communication that goes on in silence, and it can be quite powerful. So I encourage us to just go slowly with our veterans and build that trust and be patient. Let them tell their story again and again and again as we strengthen the bond, the tie. And normal questions about military service, what service, when were you serving, where did you serve, those are normal military service questions, can elicit a story indicating PTSD or moral injury or tremendous distrust of the government. And I just advise that you be prepared. And be prepared with resources, with referrals, or when you hear a certain story or a comment, know that I want to follow this up. I want to offer some additional support, resources, even websites today that can be helpful when you hear something that triggers, rather than, I'm hearing this, but no, I don't know what to do with that. I don't know where to go with that, so I'm not going to say anything. We have to be prepared and know our VA resources in the community. We've got some wonderful community-based outpatient clinics now. We have veterans centers. Please, I really urge you to get to know what services are available in your community for veterans. What are the local medical establishments that can be available for veterans? So just in your little bag of tricks, have these resources and referrals ready. Who knows when you're going to need them, but I really encourage you to be prepared. So in summary, it's really important to understand the special needs of each individual, let alone each veteran, and how their military service integrates into who they are and what might influence their health care. And I want to thank all of you who work with veterans and who support veterans, who deal with veterans on a daily basis. Veterans are everywhere. They're everywhere. And only 4% of veterans who die in this country die in a veterans hospital. Only 4%. So there's a lot of veterans out there in different settings who need our care and who need our support in different settings, because the VA cannot do it all. We cannot do it all on our own. So we thank you for all that you do for our veterans. Just to point out a couple of resources, and then I'll stop, and if there's more comments, I hope somebody might have something to say. I offer Peace at Last, Stories of Hope and Healing for Veterans and Their Families. Deborah Grassman is the former hospice manager, RN, at Bay Pines VA in Florida, has now retired. But this book is very, very powerful. Stories of Hope and Healing for Veterans. The Resilient Spirit, Transforming Suffering into Insight and Renewal. I really find this helpful about how are we resilient, and how can we nurture and honor that in ourselves and in other people. I already mentioned Welcome Them Home, Help Them Heal. Very easy to obtain from Whole Person Associations or on Amazon.com. I think it's a small little book, but very, very, very well done. And I put on there No Atheists in Foxholes, Prayers and Reflections from the Front, just as a resource for reflections. Starting a meeting, telling a little story. It's written by a chaplain in the combat zone. So he's got a little story, and then he has a prayer afterwards, and it's very inspiring. and they're short little reflections. And then this side, I put in benefits.gov for veterans, has a lot of information on federal and state benefit programs, and then a couple other websites for long-term care and elderly. I just felt that that might be helpful in the big picture. So I want to say thank you again. It was very good for me to prepare for this today, and I've really enjoyed doing it. So thank you very much, and I hope it's been helpful. Are there any questions? Please feel free to write. I had a couple of comments that I've already responded to. And I got a thank you, Penny, and I say you're welcome. You're welcome, Shelley. Thank you. Great. Good. Would you like to say?
Thank you. I'm Chaplain Wilson, Charles Wilson, and thank you for joining. Actually, this concludes the 2 webinars that were offered as a pre-pastoral care week for our October 15th through the 17th, which will be held here at VA Palo Alto Health System, and then that will spill over into the American Association of Pastoral Counselors 50th Pacific Region anniversary. If you did not get the opportunity to hear Dr. Lynn Jucknes on August the 28th, it is placed in the chat section there where you can access through the AAPC website her topic on serving women veterans. You will also be able to do that with Chaplain Penny Phillips' webinar, which took place today, and you'll be able to get that in a couple of days to hear this recording, which was done. We're excited, and I'm just grateful for Dr. Virginia Jackson to allow this pastoral to take place in October the 15th through the 17th, and this collaboration with the American Association of Pastoral Counselors. And so with that on hand, I wish you all the best, and thank you for joining us. I'm going to end the meeting for today. Blessings to you.